Thank you for that. Now we're going to move on to the last track, track 4. First up, we have Team 6.
Hi, everyone. My name is Michael Masterman, and I am a pharmacologist and a former PhD candidate at UCLA Molecular Medical Pharmacology. Came here today to discuss using open source data analysis to predict opioid overdose and reduce opioid usage. Our objective 1 was to predict opioid overdose, and our second objective was to reduce opioid usage. Problem here has been described in this auditorium today and yesterday. Public health professionals lack access to real-time data to monitor the opioid crisis. Without real-time insight in unfolding events, public health officials may be unprepared to respond to these dynamic conditions that the opioid crisis is affecting us with. This is a blind spot which can result in a delayed response times and a lack of resources needed to treat patients who have overdosed, monitor public health interventions, and productively impact the crisis. As an example, which was done in the Codeathon last year with the Origami Group in Washington, D.C., they definitively used local data to identify that there was not enough naloxone in appropriate locations, and so therefore patients died, and they needlessly died. That's just one example. We're not really going into that here, but that's an example of what's going on in real time at the opioid crisis. So this scenario may be avoidable with predictive data solutions.
So what we've done is we've tapped into Google search data as a measure of real-time, a way to measure real-time activities and crises. So we found that there are Google search terms that have an increased search rate correlated with a rise in opioid-related deaths. And we did find search terms that can be predictors of increased rates of opioid deaths in a given locale. So we can visualize that data, and this is actually pulled from our analysis, that will show people on a map, public health practitioners, where there is increasing risk of opioid-related death as a result of these Google searches, and they can then use that information to allocate resources to those areas, whether it be getting more naloxone or making sure that they're going to those communities and understanding what's happening. So we want to make this accessible via some sort of web page for practitioners to access, and we think that there could be automated data pulls from the public sources that we're getting this information from, so it's not very resource intensive. We could also have a link so that government websites can have it like a live feed to this data for people to tap into and make it very visible for the people who need to access this type of information. So that was sort of our first approach, because we really wanted to have a solution that would address what's happening right now and reducing the deaths that are happening. But then we wanted to think about it from a more long-term perspective into how are we going to reduce opioid usage. And we all know that this is very correlated with the amount of opioid prescriptions. So we first thought, okay, can we use Google search data of alternative therapies to show that communities where there's higher rates of alternative therapies for chronic pain does that correlate to a lower rate of opioid prediction? And just to walk you through our story here and our journey over the last 24 hours, we didn't find a huge amount or we found some correlation, but we need additional data and additional research to confirm that this is actually valid. I'm going to hand it over to QP to talk about something that's even more exciting, where we used quarterly state cannabis sales to see how that affected opioid prescription levels.
Yeah, so when we say it's a prediction, I mean, because for those overdose data, we only have the yearly data. So doing that kind of prediction is not that difficult. So we think we need more evidence. So here we integrate two data sets. One is the drug utilization data, that's quarterly data. And also the other one is the cannabis dispensary data. So actually we fused the two data sets to see whether there is any correlations between the dispensaries of cannabis or THC and the opioid-related drugs utilization. So here you can see from the charts, the blue curve is the actual cannabis use curve. So that's in general increasing for both states. So because we only have 2 states data for the cannabis. For the red curve, that is actually the utilization of opioid-related drugs. So in general, there is a decreasing trend. So we did find that there is a negative correlation between the cannabis dispensary and the utilization of opioids. And here we do indicate the negative correlation, this Pearson correlation coefficient. And if this correlation, I mean, this is what we observed. So if this correlation did indicate that there is such associations between them, so we can build a model to further predict, I mean, what if in the future? So here, the very light blue curve, that's the prediction of the cannabis use in the future. And, okay, and the yellow line is just the prediction of the opioid drug use. So what we are saying is that if that's the case, it's good.
We found good data. We used new data and we found some good things. This is our slide. We're just going to leave this up here. We can go right into Q&A.
So what additional data would you need to strengthen your predictions? If you had a smorgasbord of data, where would it come from and what kind of elements would you include?
Yeah, it's an excellent question. The nature of Google search and using the Google search engine, is there any sort of internet service provider? There is enterprise solutions. So in the context of a hackathon, we couldn't reach out to Google and say, hey, can we get some really localized data? And so that's a scenario. And there's literature available that suggests that in different regions, there might be different search terms might be predictive. And so that's the sort of scenario that we have, is that you have regional distinctions. You have the need to reach out to an internet service provider and work closely with them, and then be able to work and model a number of different potential searches. We looked at 10 or 11 in terms of alternative therapy measurements, and these were just things that we just thought about and said, okay, these are the most likely alternative therapy modalities that could come up in a search. But working with an internet search provider, we might be able to dial into really what are people asking and what is that related to specifically. So that's the nature there. The other thing that's happening, and with regards to cannabis legalization, is that this is a highly regulated marketplace. So the states themselves have to collect a tremendous amount of data. And so it's a great time for being able to take that data that the states have to produce by virtue of the department, by virtue of their health departments, and then integrate it right directly into what we're dealing with in this situation. So this is so that's the scenario, that there's new data sets that are coming online every day that can be accessed, and yeah. I like your questions.
Since there seems to be so stop me if I'm wrong with the interpretation, but the more dispensaries, the less the prescriptions go down. Is that correct? Or there is a,
Cannabis
I know
sales.
I'm not saying it.
So not
Cannabis
number
sales.
of dispensaries, but
Yeah.
cannabis sales.
Okay, got it. So is there, if you looked at how that impacts take-back dispensaries, or take-back when they actually take the pills and have them go to a place where people can,
Right, turn-in stations.
yes, the turn-in stations. Is there, would that also, what do you think could be done with that information?
Well, that's the thing that what we wanted, what the goal is really to create that, bring in these new data sources. And it just happened to be that in the context of a hackathon, we got exposed to, new things, data analysis scientists and a management consultant and a pharmacologist. And we really just were completely blind as we walked in the door, with the exception of maybe, a handful of papers that we know from our backgrounds and some professional expertise. And we were able to, think of the new data sets, make use of them, and then put them into play. So it's an excellent, that would be a search, that would be a criteria for a search engine. Where like, what are individuals coming up with to think, I got to get these drugs out of my medicine cabinet. This is, I need to be a part of the solution, not part of the problem. So.
We believe Ching Pong and his student, will continue to do analysis on this data. And Michael and I are very excited about implementing solutions that we come up with in our collaboration.
Other questions?
maybe my confusion in the short time that you have to present. You're using the data sets that are publicly available and using the predictive models that are, or did you generate your own predictive models?
You generate predictive models based on the data that you can get a hold of. So we, you know, we essentially, we were given some data here and dove in, and then we generated hypothesis that what could potentially be predictive. So when we're looking at alternative therapy strategies, we listed them all, say, you know, which ones might be related to opioid utilization or opioid deaths. Opioid deaths was a yearly, but opioid utilization or prescription is quarterly. So that allowed us to basically start to look at, you know, that's it. Sorry, I wasn't able to answer.
Thank you.
Maybe afterwards.
Next up, we have Team 12.
Hi, we're Team Hero. So this is Hugh, Lou, Brian, I'm Kat, and Lawrence is on virtual right now. So Hero is a smart data dashboard. Smart Data Dashboard assists in real-time collaborative predictive models with insightful visualizations. Here's some of our features. Pull from everywhere and anywhere, integrate everything and anything from all stakeholders that are participating in a study or a project. Blend and merge data from across different sources to create meaningful reports. Develop reports together with your colleagues. Share with each other for informed decision-making process, safe, secure, and scalable. So here's one example on government. Federal agencies, state, county, they might do the same kind of survey, same kind of funding for a special project. And they might not know what they're doing. Why not share with each other instead of having parallel efforts? So we know about the opioid epidemic. $500 billion gone away. So let's hear about Joe Veteran.
So in this example, Joe is a 38-year-old veteran who toured in Iraq in 2005, and he hurt his back from an injury. He's been traveling. He's been going to the VA for years to get his prescriptions to have his pain managed over at the VA, and his doctor's been prescribing opioids like fentanyl. Unfortunately, in this case, he is finding it not very effective and making him fuzzy. So he's not liking the side effects of the drug.
So Joe Veteran decided to make alternative therapy suggestions, and we decided to take into account that he wanted to try yoga and cannabis. So in 2016, this is a tale of two cities, Los Angeles being the biggest one, and we picked Boston, Massachusetts as a comparison of two cities. The reason why is Boston had a 150% increase in opioid overdoses, and we looked at licensed state and city licenses and where they were accessible. And also the deaths accounted. At this time, city and state have not gone through a lot of the issues. So there's a drop in yoga and customization, and here's another example.
So we all agree that there's so much data, more than enough that we can handle. We have data from public health, tweets, Google Trends. So what is missing here? Let's just reflect on that. Joe might be just a number in public health data or Google Trend data, but his experience with yoga may not be captured by any of the data. To address his needs, we crawled data from Yelp. We also visualize this bubble chart, which provides a big picture of what specific kinds of pain people were going through and managing using yoga. For example, neck pain, etc. And rich textual information in pain. In Yelp review data, for instance, users self-reports of their experiencing using these treatments, and they're more detailed and they're able to reach a wider population. and therefore may have really great research value for studying alternative treatments. Building upon the previous pieces, for instance, we can then address the question, how many opening yoga studios per zip code? And we visualize those potential patterns between new alternative treatments and opioid-related events. For example, for some areas, the more choices people have for alternatives, it may be the case that people are less likely to reach to opioids. Yeah, which is the next slide. So we're not arguing for correlation, but it's potential patterns. If we have better data sources, if we have more contextual information, we may be able to sort of correlate these two set of variables. Okay, sorry.
Thank you.
So, and I've got a short one and just a very basic one. Thank you. Hold that graph up there for a second. That's the very graph. This one is, yeah, retrospective data. So nice visualization, very nice, good presentation. Prediction, you got any predictive capability?
Yes, we looked at congressional legislations, federal, it's not legal at this point. We looked at state. We looked at all the medically state, and then we correlated with those who are going to be as well too. And we looked at opiate deaths. We looked at city and see where the licenses were, because testing of the product was very important as well too. So we wanted to gather that data from public health and agriculture as well too, and testing labs, and see why there's a halt in the licensing processes as well too. So we gathered a lot of state and city data just to make this. Los Angeles had more information, so that was prevalent. Massachusetts is just getting online, and so we predicted that model at this point. And right, and so, yeah, so the other one correlates the downfall, because Boston had 150% jump. The first year, it had legalized, licensed retailer dispensaries were 30% down, and then it trails down at 5%, 6% every year, and we don't have data on 2018 yet, so. So LA is a bottleneck effect, so, and then they haven't done any other efforts at this round for licensing right now.
As the mayor of Boston, what should I take away from this? Help me interpret this in 5 seconds or less.
The progression of other cities that have taken into account for the licensing and regulations, because City of LA has given more, and then you can see the trail of opiates deaths go down as well too. And so if I'm gonna only give away 40 licenses based on population, we can look at how many dispensaries he can allocate out to other applicants.
Last question, given the volume of data, how would you address the differences in the metadata and defining and how to interpret that?
So we looked at across the board nationally, but also the Cannabis Bureau and the commissioners have their own data as well too. And then the cities have their applicants licensed for all these manufacturers, retailers, and so forth. And out of that data, we extrapolated the ones that were rewarded and looked at where the locations were as well too. And those locations that had urban or socioeconomic disadvantage had a social equity program to help mitigate some of the bottleneck effect in certain areas versus the other. And then also helping other states like Massachusetts understand in a big city scenario, because we're looking at 39 million people versus 6 million people. So that scalability is more proficient in LA, and that will give a good hand to Massachusetts.
What data sets were used, especially the cannabis data sets?
We used the California California Bureau of Cannabis Control. Then we used City of Los Angeles data, so data.cityla.org data. We also correlated to, I think, NIH, CDC, and then we also did Massachusetts. They had their cannabis commission, and we used that data. So we try to be comparable to each state's regulatory controllers and city as well too. And then there's telemedicine. That's Dr. Lawrence on this. He's been with us since day one. And he, looking at data is very difficult because it's a new area or it's an alternative data. So you can prompt him in a conference, and this will help the department understand that data more equally as well too. And then also for other stakeholders like nonprofits, they might have access to him as well too. So this is Dr. Lawrence. And he's on Skype. Thank you.
Thank you, everyone. Our final presentation will be from Team 17.
Thanks for staying till the last presentation, and thanks Sean, Claire, and Stephanie for this fantastic hackathon. We had some really good presentations on what is the main crisis about the opioid hackathon, and it's been a privilege to take part in this and give us our insights into what we do. And just to give you a brief background, we've been talking a lot about opioid overdose-related deaths. Where we as a team come from is on the other spectrum. I'm a clinical pharmacologist. I'm an assistant professor at the University of Maryland, Baltimore. This is Simon Byrne at Julia Computing. He's a data solutions expert, and this is a mathematical biologist, Chris Rackauckas from MIT. And we've been working for the last couple of years on what is called as neonatal abstinence syndrome, where pregnant women are on opioids, and the babies who are born to those women undergo withdrawal symptoms after the birth. And it's a very difficult problem to tackle. There are no deaths related, but it's a social impact, and it causes a lot of hospitalizations. So, as I said, we are a team from UMB, MIT, and Julia Computing, Team 17. And today we're going to summarize our hackathon findings by showing you what, in this real 36 hours, we were able to put together. We found that there was a negative correlation with both high-dose opioids and opioid-related mortality with the proportion of cannabis consumed as edibles, right? So to put it together, for every 1% increase in edible proportion, we approximately saw a 1% decrease in high-dose opioid prescriptions. And secondly, we also saw a 5% decrease in opioid mortality. So with a 1% increase in the edible proportion of the cannabis, we saw 1% decrease in high-dose opioid prescriptions and 5% decrease in opioid mortality. Sam.
Thank you. So we made use of several public data sets, the census, CDC Wonder mortality data. The Washington State Department of Health has PMP, which is similar to appears to be similar to the California Cures too. We also had access to the hackathon-specific data sets, namely the Washington and Colorado State cannabis sales, which were broken down by different categories of cannabis and by county, and lists of clinics and dispensaries in those states. So, like the other team, we saw the general decrease in opioid and increase in marijuana correlation over time. But if you look at it as a snapshot at a particular point in time, so this is 2016, you don't see much correlation. So what we instead looked at is we started looking at factors within how the marijuana use between different areas within a state. So for example, this is Washington in 2016. Each dot here is a county, proportional to size. And you see sort of on the x-axis, you have the proportion of the cannabis consumed as edibles in each state, in each county. And on the y-axis, you have the number of rate of high-dose opioid prescriptions. What's even more interesting is that this also carries over to mortality data as well. So here we have mortality, on the vertical same x-axis, this y-axis, you have a mortality per 1,000 population. And so this is the roughly 5% decrease. And what's quite remarkable, so we found that last night, and then this morning we started looking at the Colorado data set, and we found exactly the same relationship. Colorado doesn't have the prescription data, so we were only able to do this part. But the model we fitted on the Washington data was exactly predictive of the Colorado data, which is quite remarkable. So this means, basically the same effect level, so that 5% decrease in mortality. I'll hand over to Chris.
And so what we found when we actually were looking at county by county, we couldn't find that there were, when we actually take into account demographics and income and all these other factors, the overall conclusion wasn't that marijuana was the driver towards the lower opioids, but really just that edibles were. And I couldn't understand that at first. And then when I got a ride home from a friend, and my friend told me, oh yeah, there was someone who I was working with. Remember the guy that we busted for cannabis three weeks ago? We found out that he'd been doing cocaine at work for these last few weeks. And when I was discussing with him, I really found out what the difference was. And it's that cannabis is not actually a substitute to a drug that you can keep in your pocket and discreetly use anywhere. But edibles, this is something that is. I mean, we don't want to, encourage drug use everywhere, but people are using drugs at work. Like, this is reality, right? And so even though, we picture marijuana as a drug substitute, it is not necessarily a cultural substitute because you cannot just pull out a blunt anywhere, right? Thank you. So yeah, we just wanted to make sure that we found a real effect, and we really think that maybe edibles can be a solution that traditional marijuana maybe wasn't, and this could be something for more research. Thank you.
One practical question. So it sounds like there's some distance between each of you geographically, and as we want to, with winners, continue on and implement, how would you work together? How realistic is it to continue working together, especially as, at least initially, our plan is do a lot of work within California? Does distance matter?
We already are working together. So we are part of this Center for Predictive Healthcare Analytics, and we're building this program called PUMAS. It's basically for prediction of drugs within a body, to being able to predict the exact concentrations over time using pharmacometric models. And so we already have been working on this and its applications to neonatal abstinence syndrome. And so we actually have regular meetings. We have our private Slack, and where we are able to build out these computational solutions to these healthcare problems.
I mean, the fact that we hear from different places says it.
Okay, I'm from the federal government. What do you want me to do with this? I had to ask the elephant in the room, sorry.
I think that what we need to look into is probably more research into whether edibles can actually be the cultural cure, right? There's a lot of talk about cannabis because at a general level, it seems like opening dispensaries seems to work, but we don't really know why, But it seems like when we actually look at the details county by county, it is the counties that are selling more edibles that are actually having the bigger effect. They're actually the ones that are decreasing the opioid use. And so, what we're seeing from the data is maybe we should pursue this effect. Maybe we should look into, whether edibles can really be the cultural cure, the strategy that we can kind of push as like the real thing to put on the ground.
I mean, there are similar things, like, so for example, like encourage standardized dosing of edibles and that sort of similar issues. Yeah.
So I'm with the local coalition, not the federal government. What would I do with this? So I see that you've done a study or, brought, some information together, but what is the most logical next step and how would I use it on a local basis with my, county community members who I'm trying to educate about medication safety and alternatives? No problem with that.
I mean, from a study point of view, there's obviously, you want much more detailed data. This is collected at the county level, so it's incredibly aggregated. Like King County has 2 million people in Washington. That's it's very hard to, that's a target. So you want to look at more local level data. So that would require getting, looking at the CDC. CDC data is very hard to break down, because of patient confidentiality requirements. You have to look at that in more detail. And also things like, and also of course, cheap interventions you could look at and do those from a study point of view, like encourage dispensaries in a particular area to push, put edibles at the front of the counter. That's like simple things like that are also an option.
I think that one thing that this kind of does highlight too is that, there kind of is a stigma to some of these alternatives like marijuana, but it could maybe be a safer alternative. I mean, that's why we snicker at it. It's like, ooh, it's kind of a boogeyman. It's like this new thing that was just legalized, but maybe it really could be a safe alternative. And maybe that is the stigma we might need to be overcoming to actually lead people towards a real safe alternative, because we know that not everyone can go instantly abstinent. That's asking a lot for someone who's actually going through a hard time. But, maybe if we can give something that's a safe alternative, they can have a real change.
Thank you. Thanks.
Thank you.
Thanks, everyone, for all of your wonderful presentations. Now we're going to take a break for about 10 minutes. 20 minutes? 20 minutes. So there were some really, really great presentations and ideas to give the judges time to convene and talk, and then we'll meet back here at 5:30.